Thanks very much for inviting me. Dave Coman, I'm in Brisbane. We won the premiership, by the way, for the grand final. I'm, as Emma said, a pediatrician, a geneticist, a metabolic physician to work at the kids' hospital, but also privately. I'm also one of the inaugural board members for Rare Voices Australia, and had many years on the board when we first started off. And for family reasons then, and research handed over to Louise. But it's wonderful watching voices continue to improve. So I kind of really feel that I'm a rare disease nerd, which is often how I introduce myself, really. Now, we're talking about a clinical trial that we did in ataxia telangiectasia, and it's a rare disorder, but it's more in and around some of the nuances and challenges and hurdles that we had to do to get to a trial for a rare disease. And there's a few key underpinning, I guess, messages in that. And one is the importance, I guess, of having for a rare disease a focal point or a centre of research excellence. But the other thing, which is more important, and it's the same with any walk of life, isn't it? But partnerships. You can't do any of this stuff on your own. You need to be engaged with not only your local health service, health sector, but patients as well, not only on the journey, but also in and around the trial capabilities. So look, AT, it is a proper bona fide rare disease. We have 40 odd in Australia. And spread all across the breadth of Australia, as it turns out. So it is a rare disease, but it's very much a multi-system disease. So it's kind of a combination of cerebral palsy, but a progressive degenerative cerebral palsy, a immune deficiency that gives you lungs like you get with cystic fibrosis, and you end up also having an increased cancer predisposition risk. So three pretty full-on components of a disease. And it's proper cruel, I think, actually, this disease process, because children are born very normal. And then because of the cerebellum, the way that it affects your control and movement, parents often note that they're a little bit wobbly by the time they're 2 or 3 years of age. And then we do see a progressive loss of motor skills and loss of ability to do things, to care for yourself, to just do day-to-day things, feed yourself, look after yourself after you've gone to the toilet, swallow safely, speak in a way that people can clearly understand you. And this all happens with preserved cognition, preserved intellect. So some of the genetic disorders I look after, there is a progressive degenerative component, and that also impacts on cognition. This doesn't. So the person knows exactly what's happening with them, and it's quite cruel. Now, we set up in Queensland a national AT clinic in 2007. So some 14 years ago, and it was just by happenstance. Our neurology colleague, who sadly passed away a couple of years ago, Kate Sinclair, who was a very close friend of mine, set up the clinic because there were 2 patients that she'd recently diagnosed with AT. The world expert in cell biology, just by chance in AT, happened to live in Brisbane, Professor Martin Lavin, who is from Ireland, but just happened to live in Brisbane. And there wasn't a dedicated family support group. So the parents of this particular family set up BRASHAT, a patient-based advocacy group associated with providing, I guess, support for people with AT, knowledge, awareness, but also to help drive what's called a national translational clinic. Took a hell of a lot of energy on their part, but we surrounded ourselves then with a range of clinicians and researchers to try to help move the clinic forward to be something that was meaningful and heading towards some sort of treatment opportunity. Cannot do that in isolation, of course. So you need somewhere to be able to have a trial. So that does having a friendly hospital. You do need to have a trial that is going to have, or do need to have a clinic that's got opportunities to develop research over time, but mostly you need families that are engaged, and you need to be doing stuff that's relevant for them as well. And the AT community in Australia are just magnificent people. Now, for probably about 15 years ago, 14 years ago, Martin Lavin and I had this idea that AT was probably what's called a mitochondrial disorder, so like an energy component disorder. And with some of the early research that was coming out, we'd felt that there was a way to basically kickstart the mitochondria using a repurposed medical food or oil called triheptanoin. It's something that I use for metabolic disorders. We had the cousin compound for that at the laboratory, and we did some testing on some AT cells that we had, and it was quite promising. However, getting funding for a rare disease can be really challenging. At that stage, the Medical Research Futures Fund wasn't around. It was very hard to get funding via the NHMRC, and we tried a couple of avenues, couldn't get it. But the advantage, I guess, of having not just an engaged family group, BRASHAT, but a group that links in with other international groups as well, is that it does open up capabilities for funding. Now, whilst we did end up doing some basic science research on stem cells for people with AT to prove our theory, the only way we could do that is that the money was raised by one of our AT families and donated that to BRASHAT. And to do so, they actually climbed Mount Everest, which is a pretty good analogy, isn't it? They had 2 children with very severe AT climbing their own Everest, living with a rare disease, but they did that and they raised $400,000+, which was just instrumental. And there is absolutely and utterly no way we would be here today without that input. So that's a key thing, intersecting basic science with patients as well. On the back of that then, and the strength of the science that the patient group funding allowed us to have, we were in a strong position to make an application through the Medical Research Futures Fund, a federal fund, to run a clinical trial. And our first attempt was unsuccessful. They're very, very competitive. Our second attempt, we were successful, and it was a much better application. And we got 2.5 million to run the trial, plus about 350,000 leveraged funds. And in terms of designing a trial, though, for a rare disease, a particular disease that's multi-system, that affects multiple parts of the body, you kind of have to look at a range of different endpoints, which we had decided what we thought we'd look at. But most importantly, though, we engaged the family group, the BRASHAT group, in terms of these are the things we're going to measure. Are these meaningful for you or not? Okay. Now, if you're doing a clinical trial with a repurposed drug, you need to have something robust and solid from a biological point of view to show that there's effect and improvement. But there's no point doing a biological trial unless there's a clinical improvement as well. So we did have a number of clinical scales, examination tools that were easy for us to administer. But the importance, I guess, of engaging with the families was, one, what would you tolerate? What is okay for us to do to you and your children? And we had many meetings with the families via Zoom showing, well, look, if we do this % nasal death, that's like a COVID swab in your nose. If we do these neurological assessments, that's about a 20-minute assessment for us to do. The eye movement recording, that's about 40 minutes. There will be blood tests. Is that okay? So that was really important in the design. And then particularly in the analysis too, whilst there is just some hardwired statistical analysis that happens off whatever biochemistry you get, or a biomarker, something that's a disease biomarker, in terms of the clinical outcomes, what we think as clinicians may be useful may not be that useful for the families. Okay. Really important point for something like AT, or ataxia telangiectasia, and they'll be different for other rare diseases. That's why it's important to know your rare disease, because kids with AT, generally speaking, they're in a wheelchair by the time they're 12 to 14 years of age. And those children were unlikely to be able to improve their gross motor skills such that they could get up and walk. But if we could improve their speech and language, their ability to communicate, their ability to swallow safely, their just general energy levels, that would have made a significant improvement in the quality of life for the child, the person, the adult, and the family, as dictated by the families. So that was something we put into our data analysis program. Now, at the moment for this disease process, there was nothing available. It was effectively natural history palliative care. Most children with this disease process pass in their 20s, although milder cases do live into their 40s, 30s, 40s. So we did have to do a proper randomized trial. And to do so, we had to have people come quite frequently to Brisbane over a 3-day period, and that was every 2 months apart, which produces a lot of logistics in terms of how you deliver and do these trials, particularly as kids and young adults with AT get very fatigued as the day goes on. So a lot of our assessments had to happen in the mornings. And coming every 2 months to Brisbane, if you're in Perth or Adelaide, Melbourne, it is very, very draining. So again, in terms of designing this, we only settled on doing these 2-month increments in dosage changes and assessment points after consultation with the family family groups as to what they thought would be reasonable for them. Despite all of that and the clinical trial funding, I got it, and then COVID hit. And I mean, trying to organise and run and develop a clinical trial during the height of a pandemic, I wouldn't recommend it. I mean, I'm sure I look like I'm 52 to you down the screen, but I'm actually only 25. It aged me. It was terrible. So despite us only having 40 people with AT, we had 30 in Australia. We had 30 want to be part of the trial and start the trial, which is just massive, actually. It's really good engagement. And there are a range, quite a big range, and I think that's important for a rare disease being inclusive. We had, realistically, the better people to study for this would have been the very young children, but we were adamant it had to be for everybody. And we had an age range of 3 to almost 40 of people enrolled. So we're seeing a fairly heterogeneous group, a different group of people, and it was really successful. The biomarker we were looking at in the nasal cells was very successful. Ultimately, I'm a clinician. I don't care what happens with people's nasal cells, and it was unpleasant to do, and it was a hard test to do. More importantly, though, these validated ataxia scores were statistically significant. There was improvement in them as we went through the clinical trial that reached significance, which is really important, and the first time that's been shown for this particular rare disease. Most of the improvements came in the speech and language, and again, having somebody who is in a wheelchair with dysarthria, having their speech clearer, louder, more articulating, opens up their world and their quality of life. And we also found 2 novel biomarkers, blood test markers, which are really good because we can carry that forward to a phase 3 trial. The challenge then was we only had ethics and we only had pharma approval to use this repurposed medication for the first 12 months. Now, this oil, triheptanone, I've been using it for over 15 years for some of our other metabolic disorders. If I was to engage a private company to make it, it would have cost $40,000 to make for the trial. It's simple chemistry to do, but the medication itself now has a patent on it, and there's a drug company that we had to liaise with, which is just the way the world works, and that did generate some delays and was challenging. understandably, once we'd finished the trial, the drug company did want to see data and see if there was improvement. So from time of finishing the trial in terms to having initial preliminary data analysis done and reported, there was only about 4 or 5 months, which is really, really, really quick. But then we had an extended period of negotiations with the drug company about the success of the trial and whether they would supply ongoing drug. And to do that actually is really quite stressful for clinicians, but really stressful for the families because they'd seen improvements in their child, they'd come off this drug, and they were then seeing loss of those skills. Very, very hard for families to see, hard for clinicians and researchers to see. And we did push the company pretty hard and actually enacted the advocacy of the International AT Society to help move us forward. Ultimately, then we did restart on an open label extension arm, which was for 12 months, and we're coming to the end of that. And sadly, the improvements that we had seen during the initial clinical trial had gone, and there was statistical significance in that change. However, we're starting to see those improvements come back as well, which is really, really pleasing. So it's certainly not a treatment. It's not more of a disease modifier. And whilst there are a lot of people involved in the clinical trial, these are some of the AT patients who were in the different groups. That there's the governor of Queensland, who's the patron for Wesley Medical Research. He came to one of the trials. It was really nice to the families. So I guess for me, as a rare disease nerd and an ex, original, Rare Voices Australia board member, there's a lot of value in having a centre of research excellence or a national clinic for rare disease or a type of a rare disease. I mean, if you've seen 2 kids with ataxia telangiectasia, you've seen 2 kids, but if you've seen 40, you actually understand more about it. They are a very heterogeneous population, not just rare disease, but this particular one. We live in a very big country and we must be equitable to everybody. And that does involve appropriate funding such that people aren't out of pocket to come to research clinics. And one of the biggest components of our research dollar was the travel and accommodation. But that's important that nobody's left behind. Getting funding can be very challenging for a rare disease, and sometimes you have to really advocate quite hard. In terms of clinical trials for rare disease, they're not futile things. It actually gives people hope. It helps drive forward understanding of the natural history of the disease. And even if it buys time while we look for further treatment options, that's really important. But it's important too that it's an ethical trial. Occasionally we get approached, and I certainly get approached as a clinician researcher about different types of even gene therapy options, which in doing so may be, I think, unethical. You're actually prolonging suffering by pursuing what is in some ways a futile venture. So you do need to have responsibility. The issue, I guess, then too, with any type of trial that you're running, and particularly for a rare disease, you have to manage people's expectations. So coming into this trial, we were very clear, look, this isn't going to cure your child or your adult or yourself of AT. What we're hoping is that we will see some improvements, and getting the team, the patients involved early in designing the trial really helped with that expectations, because they had a voice in how it was designed, so that there weren't any, well, you've given on this 12 months on this trial and you told us we'd be walking. So they kind of were involved and had a footprint from the start. So I guess for me, the rare disease trials are very important. It's a great way for people with rare diseases to connect with other patients as well. Rare Voices are an excellent focal point for connecting GPs and patients with different types of clinical trials or groups that have specialty with rare disease. But apart from funding being really important, the most important thing for any clinician, any researcher, any clinician researcher, that all of this rare disease research is done in collaboration with the families. Because rare diseases are rare until they affect someone you love.
I just thought I'd do a live showing. This is the kind of stuff that the Rare Portal gives you. So you go on and, just like Dave said, I'm again, like, don't Google it. If you've just told me my child's got a condition, I am going to be on my mobile in the consultation. So yeah, give me some sites to go to. And this is a growing resource.
House as well.
These are done in partnership with the rare disease organizations. And so there's kind of clear information about symptoms, treatments, and then research and data here, you know, going right back to your website where there's brilliant information. Often, you know, you want to check out who's on the board and who's giving the advice, but it's a really lovely compilation. So definitely check out Rare Portal. And in terms of sort of how you have those discussions with people, we did have a Project Echo. You might want to go back and have a look at the one that Michelle Farah did. And that was talking about the Advanced Therapies Handbook, which is now live. And there's lots of videos, but also, and I thought this might be interesting just to highlight, there's some checklists and things, because often you don't know what to ask when you've just, you know, bunny in the headlights and you've just been given a diagnosis. And so it can be helpful to have these kind of FAQs and things like that. There's the Rare Disease 101 e-learning module, and there's a whole resource lesson there on research and new therapies that you might find interesting. In our national recommendations, you know, one of the ways of dealing with the inherent uncertainty is facilitating connections with rare disease and patient advocacy groups, research, including clinical trials and new therapies and technology. And I guess this is our starting point. The less than 5% of rare disease have a curative treatment, which is why clinical trials is often so pivotal. And if you go through there, it's got connections to some of those resources we talked through. And we talked about the Advanced Therapeutics Handbook with lots of videos, infographics, simple information. I learned a lot by being involved with this project.